So one of the things that we wanted to show you is not just what it looked like for 2021, but kind of give you the whole picture on what happened prior to COVID, what happened during COVID, and afterwards. What you're seeing here in the dark blue are your actual per member per year amounts. And so you see in 2020, there was we were going from 2016 up to 2019. It was kind of a normal progression. And then in 2020, a big drop, and then a big increase there in 2021. Now, when you look at all 5 years, your 5-year trend still with that is running at what we're seeing at 1.6%. So, which is a great trend. The light blue bars are what we show would be the estimated trend for your industry. So K through 12 education, which is running at 3.4%. So as a group, you guys are still ahead of what the norm's doing. And a lot of that is really from just the culture of wellness that, everyone top to bottom has really helped do. Because that way we get folks in for preventive things, and we have less what I call avoidable hospitalizations and major claims. So this kind of gives you a shot, because of all the different things that we did over the years and what those helped save the plan. And I always, whenever there's a number there, I like to say that is what we project in our business, that groups who don't have what you put in place are having for claims. Okay. So it's not actually a savings, because it's claims that you didn't have because your members have the diabetes health plan and things like that. So the first thing was, again, right around 2012, we put in the diabetes health plan. This program helps for those who are diabetic or pre-diabetic, gives them lower copays to go ahead and make sure that they're getting their medication, getting their doctor's visits. And what we were seeing is, on average, that's a $2.3 million cost avoidance because people are taking their medication. Excuse me. We started the health rewards incentive program. At this point, it was just doing activities. And that's a $0.7 million savings, because those folks who were doing the activities were having less hospitalizations because they were having preventive services, and then they were having other services that, if something was seen there that they needed to have, they were having outpatient. We started our on-site nurse liaison, who worked with a lot of these members who we see weren't in compliance, and tried to help educate them. So, we were looking at about $3.3 million in cost avoidance from that point. In 2014, we eliminated the PPO option and added the consumer health plan with HSA option, which was a $0.2 million savings that we were seeing. And we also transitioned to DHP Plus. The plus is now we added people who had high blood pressure and high cholesterol. So these are kind of the folks who are your pre-diabetics, stepping back. And that gave us a little bit of savings as well. In 2015, we actually moved the health rewards programs to outcomes based. So this is where you had to meet 4 out of the 5 markers on your biometric screening. If you didn't meet them, there were reasonable alternatives. One of those is always a physician, if you're having a treatment plan with the physician. We also launched the very first telehealth kiosk in the country in a school district. You guys may remember the big blue thing in the lobby for a while there. We were actually on NBC Nightly News with that one time. It was a great idea, but not really well taken and well received. It's kind of fun to look at that now and look at where we are with telehealth. We added the Real Appeal. That's the nutrition weight loss program that was added mid-year. And so with all of those going on, the kiosk is just in there to remember what we've done. But that really didn't add much to savings at all. Although we do have one member who we know, because she was in the news story, would have had a 4 to 5 day hospitalization had she not used that. So we're looking at 3.8 there. 2016, what we did here is within United Healthcare, we have premium providers. They're tier 1 providers. These are providers that over a 3-year period, we see deliver better results and at a better cost point and everything. So the key thing here is, first of all, their outcomes-based measures are much better. And so what we did was we made that copay differential on the HMO plans. So if someone goes to see a tier 1 primary care or specialist, they have a copay reduction. We added a port of medical necessity into the plan. And the interesting thing here is that United Healthcare, on our fully insured, we add different parts of medical necessity regularly. Okay. So the benefit to the district is usually you guys are probably about 6 months to a year behind adding what we've added on our fully insured. And we kind of do this intentionally because we know one of the key things is you don't want noise. You don't want members having issues. So United Healthcare with our fully insured members kind of works out the kinks ahead of time. And then we come to you and present these as ideas. So when we added that, you got increased savings from it because now the doctors were following the orders that they should have been doing, but a lot of them were doing it already. So it's not something that creates a lot of noise. We also added the health rewards program and coaching tool. We transitioned to our new Rally, which is a more engaged tool, and added virtual visits as an option. And so we saw 4.9 million there in savings. Apologize. In 2017, we rolled out the Diabetes Health Plan Plus 2.0 version. We're constantly updating these. And just so you guys know, whenever we roll something out like that new, you get it automatically. There's no change in the fee. There's nothing that we increase your costs that we're charging you. Diane and Marilyn, for years, and now Nancy have always said, yes, we want it, but we're not going to pay anything more for it. So that's my marching order when I go back to my staff. In 2018, we started a new focus claim review program on orthopedic surgeries. What we do now is on certain surgeries, we'll look at them based on the amounts, and we actually get all the surgeon's notes. So you're talking, 100 to 200 pages of notes. We have our surgeon go through and make sure that the claim matches up. Okay. Because there's a lot of times when someone's doing a surgery, they say, I did X surgery, and there's all these codes that get automatically included. Well, unless you look at the notes, you can't see, well, maybe they didn't do this code and it shouldn't have been billed. Okay, so it's really getting into the details on that. 2019 was probably the last time that we did some major plan changes. This is where we changed you guys agreed on changing the emergency room for the high HMO, which delivered a $2.2 million savings. And then we also excluded Walgreens on the pharmacy. It used to be you could go to CVS or Walgreens. We had come in and said, hey, look, if we are able to just go one or the other, we're going to get increased discounts from whichever one is the one last standing. Okay. We decided because CVS had the minute clinics, which really helped with the biometric screening abilities, that we stayed with CVS. So that was delivering 5.6 million in increased discounts coming from the pharmacy by pulling Walgreens out. In 2020, we changed your clinical platform. PHS stands for Personal Health Support. You were on 2.0. Now you're on 3.0. I know that doesn't mean a lot, but from the just by the numbers. But what this does is it has a much deeper way that we look at the data and look at a member and then really look at not just what a member's condition is, but what their willingness probably to, and we use artificial intelligence to look at it, what their willingness and opportunity is to make a change in how they're, where they are. And then we direct more resources on those folks. Okay. So it's really, looking at the folks a lot closer. We also added orthopedic support. One of the key things with orthopedics is, as a friend of mine who's a orthopedic surgeon said, he goes, well, if you've got a handyman and only has a hammer, everything looks like a nail. And so what happens a lot of times is when someone is in an orthopedic surgeon, they get paid to do surgery. So what we have done is we're doing a lot more to look at folks who may have different indications that they may be looking to have surgery. And our teams are reaching out to them and saying, hey, instead of going to an orthopedic surgeon, based on what we see here, why don't we start with a chiropractor? And why don't we look at some less invasive ways? And that helps deliver some savings. 2021, we came out with a new variable RX copay program. And this is where our team leverages the different copay programs that different pharmacy manufacturers give. Again, everyone else but you guys would have had a PMPM increase, but based on the rules that I'm told, I was able to get that delivered to you guys at no cost increase, and yet it delivered a $1.8 million savings. The other thing we did is separated the employee and spouse on the, not in real life, just want to make sure that we only in how they get the health rewards. It used to be that both the employee, if they had a spouse or domestic partner, they both had to do it or they got nothing. And now we have it separated. And then this year we've added what's called Second MD, which is a program that allows members, if they've got a diagnosis, it allows them to call our Second MD team of highly trained surgeons in different fields. They will collect the notes from the doctors on whatever treatment is going on. And then from there, we'll say it's more of a collaborative process with the doctor, the attending doctor, to see, okay, is this the best course of action? Or, it might be the best course, but they might say, hey, instead of you having it here locally, maybe we need to bring you up to Ohio for, a Cleveland Clinic or one of our centers of excellence. So that one was just launched. So it's a lot of material there. Again, you guys are constantly looking at, but any questions on this?
Just one, and maybe I'm misremembering, but in 2019, wasn't there also an increase to some copays of like $5 per doctor's visit or something? There was like one, like vaguely recall an additional change.
We made a change in the deductible on the high option plan. So we did increase the deductible
Okay.
on the high option.
And do we know
We added, Jim, do you have the ER? When did we do that?
Well, that was 2019.
that was all we did a bunch at once.
Yeah, we changed from a copay on the high option for the ER visit to a percentage of co-insurance amount, and we increased the deductible on the high option plan.
Okay. Yeah, I thought there was something generically like the copay for doctor's visits went up like $5, but I could be misremembering.
Well, that bullet point, the 2.2, is all the change difference from 2018 to 2019. So
Okay.
that would have been included. The biggest item, though, in that driving
Yeah,
the savings was the ER change.
Okay.
I have a question about in 2021, the employee and spouse. Do we know, did any change take place in level of participation as a result of that change?
Well, we do know that we have a lot of employees whose spouse didn't do stuff who now are getting the reward, and vice versa. We have a number of spouses, domestic partners, who the employee is seeing that benefit. As far as overall, the trend on the health rewards has been down, and 2021 was coming off of COVID and everything. It's a year that it's lower than it has been. Each year it's kind of dropped off, and that's where we're looking to kind of change that up a little and try and rebrand it. On top of that, we're also looking at your support for us to come out and help. Jeez, always happens when you start talking, you get a
Right.
sore throat. But there are folks who have benefited by that.
So I guess basically we just might not be able to see if that benefit or if that change has any benefits yet, just because of COVID and
Yeah.
how people changed what they do and going to doctors and things like that.
Yeah, correct.
Okay.
I mean, overall, we've seen that the health rewards program, and I can show a slide here in a little bit. People who are involved in it have lower claims because they have, and we call it the health activation index. They make better decisions when it comes to their medical. So that's a key point of the program, is it makes better consumers when it comes to your health choices. Okay.
Thank you. And I just want to point out that that was something that was requested in the last session, to see how the changes that have been implemented, did they really do anything? So thank you
Right.
for that.
So again, just focus in on 2021. As I mentioned, this is the crush. So you see we had, spend rebounded, which is not always a good thing. 10.1 from 2020. But if you look at the average between the years, it's only 3.3 per year percent average. COVID-19 drove about 10% of the spend. We started getting folks back in for their screenings. This is the one that I really am concerned about, is, when folks stop going to the doctor for their screenings and everything, that's when things develop. And some folks will sit there and not ever get back into the routine. So that's a key thing. They're up, but not where they had been. ER use, we had been fighting this for many years, getting the non-necessary emergency room use down, but it jumped up, as well as outpatient surgery. And the engagement year over year in folks using the program and everything has increased. This is a real busy slide, but what I want to kind of focus on I hit the wrong button. Here we go. Is the top right corner there. So what we did was we took out. Hold on, there we go. Top right corner. We took out, or we separated what your COVID-19 claims were. So on the left top, you see the medical plan. In 2019, it was $328 PMPM. In 2020, it went down to $318, and then in 2021 jumped up to $350. But if you look at the middle section, that shows you, okay, 2020, 15 of that was coming from COVID, and in 2021, $35 PMPM was. So if you pull those out, your 2021 number is actually a decrease from 2019. So, it's just amazing at what happened there. If you think about it, increased testing, the vaccines came out, and it was somewhat of a free for all on testing. Most of your plan, everything has to go in network. Now, we did really try to focus folks on using the county free resources. That was something that we were promoting for testing and that. But, I'm sure you guys have driven around and seen the pup tents where people go, and that was really difficult to try and maintain costs on those. So any questions on the COVID info?
Is that 1.6 total in 2022 from January through April or May?
This report, that is through March, only through March.
Okay.
Yep.
Thank you.
Jim, is inpatient also considered there? Because it seems like, people were
Yep.
hospitalized for days and days on end, which is, very expensive.
Yeah, the inpatient is your confirmed diagnosis. That's kind of everything rolled in there.
Mhm.
So we wanted to show you what the testing and vaccines were, and then the others are treatment, whatever it would be. Okay, so again, we kind of talked about how did you bounce back in 2021. So the light blue here is showing you 2019 to 2020. And then the dark blue is what happened from 2020 to 2021, the rate of change there. So, surgical admits were way down going from 2019 to 2020 because, again, the hospitals were closed unless you had COVID pretty much. Same thing with outpatient surgeries. So we're seeing, surgical admits, a change of 24% there. Outpatient surgeries, a change of 34%. Emergency room was off the chart there. So that's definitely an item that we're going to be focusing on. And urgent cares, it's interesting. What we saw was in 2019 to 2020, folks were going to urgent cares when they needed it instead of the hospital. But then all of a sudden, when we had the things going on in 2021 early on, people left the urgent cares and went to the hospitals. So all the training that we tried to do went out the window. We did see the increase there of 9% in adult wellness exams. Same thing with breast cancer screenings. And the other nice thing that we've seen is the behavioral health specialty care. That's something that we're definitely trying to promote. It was something that prior to COVID was underutilized. And one of the silver linings of COVID now is the focus on behavioral health, just in the community. Okay, where are the drivers from? So you have your cancers are your neoplasms. That's your top driver there, with top detailed ones are breast and lung cancer. Then we have the COVID-19 is the second area, is the main driver. Then we have what we call other conditions, wellness visits. This is also your preventive screenings, things like that, which is a good driver. Those are the things that you want to spend your money on. And then we get into circulatory system. And the last one is what's called MSK, musculoskeletal, which are your surgeries, spines, joints, things like that. And the reason I highlight this is that when we're looking at, okay, where are we going to focus our time? We look at the big drivers, then we go into them and go, okay, breast cancer. Okay, that's something that there's a preventive test for. So we need to focus on getting more of those done. Lung cancer, not really a preventive test, but you the doctor will start to see things regarding lung cancer when they're doing a preventive exam. So if we're able to look at someone who's developed lung cancer and see that they haven't had any preventive exams in a few years, that's an aha moment that, okay, we need to really help folks have those done so they can be caught earlier. Okay. So when looking at how do we try to, where are opportunities in those areas? Diabetes is by far the number one just across the board, because any one of those conditions typically comes with a comorbidity of diabetes. So that's why we're always really focusing in on that. And as we saw in COVID had a uniquely adverse effect on folks with diabetes. Okay. It was, if you were to have a virus that would attack someone with diabetes, this was it. So this is where, we are spending a lot of times on making sure that we get folks in to have their provider visits and A1C testing. Musculoskeletal, as we said, there's a lot of key surgeries that we've seen happening. And in some of the cases, or in a lot of these cases, we could have looked at something less invasive that would have, first of all, probably been a lot better for the member in that, had something like chiropractic or some other less invasive things, they wouldn't have had time out due to surgery, the medications and everything like that. And it would have cost them and the health plan less. And that's where we're talking about Kaya Health is a virtual program that goes ahead and works with folks nowadays with your smartphone or tablet. It can help you to do some of the exercises and other things ahead of even going to a chiropractor. Cancers was the other area. Again, here, as we look across there, breast, prostate, colon, those right there are ones that if we're able to increase our screenings more, that early detection will happen, and that will help to lower the overall costs there. Okay. So there's a lot of things that we do in the background, and that's why I wanted to include this when we're looking at pharmacy and medical. Because a lot of times folks think, oh my gosh, we've got these new higher cost drugs and, someone's going to have this and it's going to be a claim cost and everything. And we do a lot of integrated medical analysis on, okay, does it make more sense to have an operation or some kind of procedure medically, or does it make more sense to use one of these medications? And it's not just on a cost basis, but it's also on, okay, what is going to be better for the member as far as their overall treatment. Everything there is based on outcomes based, PDL and utilization management. The prescription drug list, we update that 3 times throughout the year. And what we look at are trends going on in the market. So as, let's say, a drug that's a brand name is getting ready to come off of the brand, ahead of time, what that manufacturer might do is increase rebates. Okay. And so when we look at it, even though you would think a generic would cost less overall, when you factor in the rebates, the brand might cost the health plan less than the generic. And so what we'll do is we'll say, okay, now the brand is a tier 1 and the generic is a tier 2. So that's why sometimes those things happen. Another big thing is site of care management. So if you're having something done at, say, a hospital infusion center, That's the most expensive place. If you're having it done at the doctor's office where they can do the infusion, or if, we also do home infusion or we can come to the home, those are much less expensive. So we're constantly working with members on those kind of things. Now, with that said, that can be an uphill battle because doctors and hospitals make a lot of money off having the infusion there. So that's where we have to do some education. We were able to, during COVID, roll out the home infusion for the monoclonal antibody treatment, which at that time, again, was tough to get. People weren't traveling. People with COVID didn't want to go to the hospital. People in the hospitals didn't want people with COVID going there. So it really helped to get a lot of folks using that form. And that's something that we're developing more as we move on. So this is just looking at your pharmacy for 2021. And these numbers are, the increased numbers are a little different. So I want to take a minute. So when you look at the first one there, pharmacy paid per member per month. So your prior was 120.75. It went up to 124.39, which is a 3% increase. Okay. So from 2020 to 2021, you had a 3% increase. In 2021, our norm is now at 120.57. So you guys are ahead of the norm in your spend, in your actual spend there, 124.39 versus 120.57. And part of that is because you've got more folks compliant on their medication. So that's a good factor actually to have. But that 11% increase, so all the rest of our book of business, while you guys had a 3% increase for that, they saw an 11% increase. So your increase is less than what the rest of the book of business is showing. And that's how you read those numbers when you look at non-specialty and specialty. So whereas on the specialty paid, you guys are at 1.1%, which is less than inflation at the time, where the norm was seeing a 15.6% increase. So, some really good numbers there. One thing that some people look at again is the generic dispensing rate. You guys had there in the middle bottom. You went down from prior. Oh, thank you so much. But part of the reason why that went down is, and it's underneath there, is the vaccines go through, they're considered generic. So all your vaccines, and we had to pay a certain amount based on the federal government to have those administered. The vaccines were free, but the administration added in there. So technically, if we took the vaccines out, which kind of messed your numbers up, you would have been at 88.1%. So again, great generic dispensing rate. Any questions on your pharmacy numbers there? Oh, okay.
Sounds like somebody does.
Oh,
Go ahead and unmute yourself. Can't see from here who that was.
Stephen Voss, I'm with ASOP. Have they considered going forward any, we all talk about sticks, how about any carrots to get people to get more up on their vaccines, like COVID and I guess influenza for one thing?
so let me make sure I got the question right. Are we doing anything to
Incentivize vaccination.
folks to take the vaccines? Was that the question?
Not just COVID, but there's also, influenza,
Sure.
all the common vaccines, because they seem to be a cheap way to reduce costs to the members.
Yeah, from the United Healthcare standpoint, we're constantly reaching out to members either through email, through their portal and everything. I mean, if you go online, the first thing that pops up is it'll have how many recommendations you might have. At one point earlier this year, I had 15 recommendations. I'm now down to 6, so I'm doing pretty good. And those things will be there saying, get your booster or get your, your flu shot. Or for folks who are older, it might say the shingle shot, those kind of things. But from an aspect of the health rewards program, I know we've talked about the concept of maybe seeing how we can put some kind of other incentive in play, but nothing other than some
I
discussion.
mean,
Yeah, but
even a simple, flat rate incentive for like, oh, hey, get your flu vaccine, we'll give you $20 or something. Even something that obvious.
Well, isn't, with our plans, those things would all fall under preventive, correct?
Correct.
Yes.
So it's no cost to the member to get their preventive vaccine. So I think it's, maybe we can do campaigns to help encourage people to know where to get them. Also, let them know that it is free and,
well-
keeping us all healthy.
Also, in previous years, we had clinics come to the schools. Now they stopped coming.
Yeah.
You know, vaccine. You could get your vaccine on site.
Yeah, that's something that we had been able to do previous to COVID. You've got to understand with COVID though, there's a workforce, not that you guys know anything about problems getting people to be able to fill the classrooms and everything. There's a similar thing with medical staff to be able to come out and do those. But that is something that we've talked about working with the wellness champs at the different sites to see about having that happen when we have vendors who can do it.
Okay.
Yeah, great idea though.
I think that if you could get the particularly the flu vaccine, the number of days lost to influenza, I think that would reduce healthcare costs quite a bit.
Okay. Yep, we'll take that as a takeaway to see if we've got capacity from the vendors to be able to do that. Okay. As I mentioned earlier, this slide kind of talks about where site of service happens for a lot of things. So kind of in the middle there, you'll see oncology. A lot of that is happening in an outpatient hospital facility. And then you have the physician office next. So anywhere you see the dark blue, that's really expensive treatment. So one of the things that we're working on right now is how we can drive some of that more to the doctor's office or having a home infusion happen. Sorry about that. I mentioned behavioral health. So as a very bright light or silver lining to COVID, what you see here is 2020, the beginning of the year there. The gold or red is where you're able to have virtual treatment. So you see all of a sudden it's blue where people are having in person, and then it drops there in March and April. And from there, all of a sudden the virtual gold takes over to the point now where, we're seeing, some of the virtual being greater than in person. So this is great news because not only are people having treatment, we're starting to see a mix of more people. For instance, gentlemen tend to not have behavioral health treatment as much as women. And now because a guy can go out to his car instead of having to go into a building, he can have his session there in his car with his cell phone. We're seeing a lot more males take advantage of this. And when you look at this, whenever we look at someone who has got a medical condition, they typically have a comorbidity of some kind of a mental health problem as well. Okay, so just think about it. If you're diabetic, you're overweight, you've got a bad knee, you can't do anything, you're also going to be a little depressed because you can't do things like, with your kids and grandkids. and so not addressing that mental health concern hinders your recovery on the medical side. And that's why we're doing a lot to really reach out to folks and say, hey, we see you have all these conditions and you're kind of working on these, but our clinicians are asking them, have you talked with a mental health professional about this or that, and getting folks engaged in that treatment to really help their overall health. The button break. Can you, I guess, advance it for me?
Yeah, I don't know why.
I think my battery died.
So I did move this thing out of the way, but that shouldn't mean anything. So why are we not advancing? What is that? Oh, thank
Battery
you.
dead?
Just magically out of nowhere appears somebody who knows.
there
what
we
they're
go.
doing. Thank you.
So here I wanted to show you your health rewards. Again, I mentioned Real Appeal. It's a program which you guys actually helped us pilot. It's a great program to where folks are able at no cost to them to have a nutrition weight loss coaching. It's virtual and we've seen some dramatic numbers. One of the key things there is that 86% of the folks at risk are in this, excuse me, let me take that back. Out of the 4,500 and some folks who are in the program, majority of them, 86%, are what we see at risk. Of those, we've seen on average about 35% will lose 5% of their body weight. Okay, so there's a lot of percentages there, but of the folks at risk, roughly a third of them are losing 5% of their body weight. And the reason that number is important to us, because we've seen that studies show that if you are obese and lose 5% of your body weight, you've just reduced your chance of a heart attack or stroke by 50%. So very dramatic. Health rewards program. We have seen that this program in getting folks to know their numbers and then to have to take some action has really produced to where, okay, folks with a higher BMI are making a change and getting their BMI down. Same thing with blood pressure and total cholesterol and glucose. So you're seeing the numbers there, the number of folks who had an elevated BMI there, 52, 45, and you're seeing that over the course of the next year, 46% of them have reduced it. Okay. So the health rewards program is getting folks to make action. And the bottom item there, members engaged, and we looked at 3 years because we didn't want to just look at year over year. We looked at 3 years. Those members engaged 13 points higher optimal healthcare decision making. They have a 12% lower costs per claimant. 7 points better when they have a chronic on their chronic condition compliance. 26% lower emergency room. So again, really helping to teach folks what we call health activation. Again, this is your the best way to think of it is how smart you are about using the healthcare that you have and making the best decision. So more informed decision choices. Someone who has a higher activation in your group is showing a monthly allowed per claimant of about $475, where those who have low activation, $630. On average, the middle number there, for each 1 point of improvement we can do in your health engagement, index, your health activation, it's going to drop your claims by 0.56, which when you're looking at 219, 220 million, that's some big numbers there. So that's why when, I come to you and say, one of the big things we definitely need your help on is, and again, we'll come out to any of your meetings or whatever to help promote the health rewards program and getting folks to get involved with it, because when they're involved in that, they make better medical choices across the board. So recommendations here, again, when we look back, I always look at where are your cost drivers, what can we do to help mitigate those moving forward. Cancer's number one, promoting the preventive services. And a lot of this goes hand in hand with health rewards. Musculoskeletal. So one of the big thing there is to promote folks calling up if they're having issues there. And also the other item we talked about is Kaya, which is implementing that program. Outpatient surgeries. The idea that we've put here, your outpatient surgeries are increasing. What we can do is we have a program called Surgical Management Solutions. What that program does is, instead of letting the doctor go anywhere, say here, you want to go to the hospital, have it done, or you want to go here, we look at these outpatient centers. Okay. So for instance, earlier last year, I needed a colonoscopy. Our plan has this in place. So instead of my doctor going to one of the hospitals, he had me call this facility. I called there, made my appointment. They said, okay, you come at this time. Here's how it goes. They say whoever's dropping you off and picking you up, when you come in, you give us their number. They don't come in unless you need help, like moving or whatever. But we'll text them, call them. They give an estimated window on when I'll be done and everything. They text and call. They come pick you up, and you go out the door. It's I don't like to use the word concierge, because people think, you got, pillows on, chocolates on the pillows or something like that. But it is a very efficient way to have your services done. And so that by doing it there, you're able to control costs a lot more. A couple of new programs here. So one of the things that our partnership over the many years, you guys are probably one of the more progressive public sector groups out there. Diabetes Health Plan was a program that was piloted and initiated here with our partnership with you. The telehealth kiosk, Real Appeal, a lot of these. So we're looking to start a virtual specialty women's healthcare program. This is a pilot program, again, at no cost to the district. So that's something that we're going to start. From there, that may develop into where we can see some savings. Offhand right now, the idea is that we're going to be able to reach out and probably have some women who are just dealing with a situation in silence, because they think this is how it should be. Okay. The other thing that we have is a group called Spora Health, which is a virtual primary care for people of color, because the studies have shown that there are some folks who, have different barriers to how they get treatment. And so this is helping to take some of those barriers out in delivering care in a way that is more receptive. So those are some pilot programs we're looking at starting. With that said, I guess this is kind of the money slide here. So right now, as mentioned by Nancy, we have some new radiology and cardiology medical necessity programs. And when we talk about that, this is just kind of the guidelines for normal treatment. Okay, if you're going to have this kind of radiology or cardiology, 95% of folks can have it as long as they pass the guidelines that we put in place. Obviously, the provider always has the ability, if we say no, it doesn't meet the medical necessity, the provider has the ability to appeal. They have the ability to have a peer-to-peer call with our doctors. And as I mentioned, these programs are in place on our fully insured. And that's the radiology and cardiology we see would be a savings of 1.7 estimated. Medical necessity, other add-on programs, about 678,000. The surgical management solutions that I talked to you about there just a minute ago, that's about 850,000. And then the Kaya program we see could generate 738,000 in savings.
Any questions here on these slides, on this slide?
I've seen just over my career in South Florida with health insurance that, it's so darn litigious in South Florida. And so doctors do tend to overprescribe a lot of these radiology and, various things like that. And so, we always want to make sure that our employees have access to everything they need, but that it's not just prescribed unless it's medically necessary. So
That concludes everything I had.
okay.
Thank you.
Unless you
Gosh,
want
you guys, that was
more, I probably got 150 more slides. and-
that was really in depth. Thanks for your attention. Does anyone want to take a biological break before we talk about the article? We good? Shall we just keep rolling on? All right. Okay. All right. Let me figure this thing out again. All right.
That sounds good.
No escape. Okay. There we go. And here we go. Okay. So, we had told you that we would meet with you quarterly to go over the actual plan, and that's kind of what we just did. We also are looking at kind of a simplified way for me to send to Tim just some monthly claims experience, just so you can kind of look at it, just a simple one-pager that kind of shows how our claims, if you want to see our claims, I want to see them under 18 million a month. With our drugs, under 4 million a month, but sometimes they creep up to 20. So, we're looking at that in real time. So we'll keep you up to date with that too, as we watch the progression of the plan. So everybody has a copy of the article. Is that correct?
Yes, except for the people that are online, but
Okay.
I'll share that. Here, if you want to make it present so it's a little bit bigger on the screen.
Yes, of course. Yes. Here we go.
Yep.
There we go.
So these might be different article sections based on the bargaining agreement that we're talking about, but in the handout that we have and that I'll share with those of you who are online, this is basically the section you'll find it in. So what we're proposing here are some most of what you're going to see here is just very minor adjustments. Some are just dates, some are language cleanup, very minimal changes that you'll see here. But ultimately, as far as increases go, you want to share anything on that?
Yeah, so as we discussed, our intent is not to impose an increase for plan year 2023, which begins in January, but instead to sort of just work with you collaboratively to watch this thing and manage the plan through the areas that we've discussed.
So in an effort to get there, that's where you saw on that last slide of the presentation, these were some of the recommendations to help us keep plan under control and avoid a premiums increase.
Right. Yes.
So if to go through this, I'll leave that. We'll leave that up there for now. But those of you who are here, the first one is really just a date change to 2023. That's the effective date of the new plan. For 2, it's just clarifying some language regarding the amount of supplemental life insurance an eligible employee can purchase in the first 30 days of employment. That is on second page towards the bottom, and it should see it highlighted in red.
Yeah, and that's just a language clarification. All of these, the clarifications are really just language,
Right.
making it
It's not
clearer.
actually a change in what's offered. On the article, let's see, section 6A, these are, in the last round of bargaining, this was prior to me being here, prior to Ms. Bolden being here, it appears as though the agreements were not updated to match what was produced in the employee benefits guide. So the numbers on the employee benefits guide were correct, but for part-time employees, and that we have 113 of them who would have fall into this category. But what you see here is on the numbers for part-time, the actual district contributions were different than what you see there, and this is updating them for 2023. But to address the difference in what the bargaining agreement has and what the benefits guide has, this was not any additional cost to the employees. Do not account for any additional costs, deductions in their paychecks or costs when they went to get services. So it was just what the district would have contributed to their own fund, being self-insured, if that makes sense.
And we've spoken with Ms. Howard, and of course, Marilyn has the historical perspective back several years, and we just don't know why these part-time rates were not reflected the same as in our benefits booklets. But, we're self-insured, so these premiums are just estimates. And for a group as small as the 113 part-timers who choose that high deductible plan, that high HMO plan, chances are the district is contributing more than what those rates reflect, just based on the claims experience, because it's not cheap to be in that plan. So, it could be pretty claims driven. But their rate has not changed over the 9 and 10 years referenced any, as the rest of the plan participants' rates have not changed.
Do you have the year that, because I'm assuming, just using the first example, the 540 versus 440,
Yes.
at some point in time, it was 540. And then some sort of change through negotiations led to it being 440. Do you know what year that supposedly took place? And
No, I went back through, and the best way that I could describe this is you have a total, what we said the premium would be. So we've had several times that the district amount in our contract has changed. And throughout that, 9 to 10 years, the guiding principle that we have negotiated is that there would not be an increase to the employee. So where we got a skew, I think may have been around 2017 in the contract language, but all other information, reference guide, PeopleSoft information, any information that was, our rate sheets, all reflected to total to what we had agreed upon would be the total premium cost and keeping the employees level consistent. So I don't know if this got askew. At one point, I think we had proposed that we would reduce our amounts, that we would have, the wellness came into play. So I don't know if it was just a typographical of copying and pasting that created this issue or not, but the actual cost of the employee, as I look back from 2012, that's remained constant. It's this board amount, and only since about 2017 that the contract has reflected this disparity in being consistent to what every other published rates are.
so I guess, though, not that I don't take everyone's word for it, but is there any documentation that shows a signed agreement that reduces those numbers? Or are you saying that as a total part of the cost, there's the employee and employer portion, and that total, say, was $1,000, and those two numbers together are adding up to more than $1,000?
That's exactly,
Okay.
if the numbers as the strikeout numbers, it would have exceeded what we said our total rate would be. So this is getting in line with what we said the employee cost would be. And if we use the numbers that have been stricken out, and that's why these are at some point, like I said, I don't know if it was a copy paste type of situation. If we combined those numbers with what the employees has consistently paid, it would be more than what we said the total contribution amounts were.
Okay, so there's a flip side to this, and that is what the employee pays. And is there a separate sheet? Because we normally get that separately, because it's not what the employee pays is not a part of the article. It's,
Correct, and that's what I'm saying to you. That has been consistent and has
Right.
not changed, yeah.
right, but can we get a copy of that? I
Yes.
guess that's what I'm
Yes.
saying.
Sure, we have
Yeah,
them,
so, because we're talking about something in the air, and we need to kind of see exactly
Sure.
what we're talking about.
yeah. I mean, I have it here. I don't have copies, but we can get copies to you.
Okay,
We'll
All
get
right.
those to you, absolutely. And, we do an annual open enrollment, of course, as you know, every year where those rates are consistently published. I don't know how this happened. All I can imagine is that, like Marilyn said, it's a typo. But we have to correct it, obviously, in the contract so that it reflects everything else that's published. And it's only those 113 part-time folks.
Most of which are fall in CTA. 101 of them are in CTA.
Sorry.
101 of them are in CTA. So, but again, it's just what the district pushes over into that fund, right? It's not, it doesn't impact, but we will share the benefits guide information and how much employees are contributing. All right.
And that we are talking about this now, will we get the cost sheet for the members in terms of what they pay for the health insurance? And I guess it'll just be the same as it was the current year.
Yes.
Okay.
Okay.
Yeah, these strikeout numbers, it seems that when we went from contract 2017 to 18, that's where these faulty numbers came into play. I'll get you a clean copy. I think this is what you're referring to.
Right.
So I'll get you a clean copy. It just has my pen markings on it, but this is what we'll get you.
Right, because
Even just if it's from that specific time frame in negotiation, a copy of the TA documents at that time too. 'Cause that would be the background that would lead.
That's probably
to-
something I'll have to pull. I'll look through the records because they're probably
Okay.
in my office. Mr. Voss?
Yes, I tried to bring this up during our original bargaining agreement, and I don't know if this has been addressed, because we have some employees that are part-time in one bargaining group and part-time in another bargaining group. They have two jobs that their total hours would normally put them equal to what a full-time employee works, but they're not treated as a full-time employee when it comes to health coverage.
If they have regular part-time positions, systematically, if you have someone that is falling into the category you're describing, please let me know. Because systematically, we're looking at the FTE hours, and they would be equivalent to something as long as they're working enough hours in both positions to equate to a total of 30, they would be eligible. So if you have someone in that situation, please get them to me so I can take a look at the record.
Not to mention that would be at an ACA violation too.
Yeah, and I don't think it was, obviously, I don't think it's intentional, but I think maybe something in the language, maybe they don't even know they're eligible.
Well, what I'm saying is if when we say part-time, we have part-time temps, we have part-time regulars. So I just need to look at the details of how they're classified so that we can make sure, but systematically, if they're part-time, and again, the teaching bargaining unit is the only one that has part-timers, one position that would be eligible. But with the other bargaining units, if there are two part-time positions that the equivalent hours equals a full-time position, they should be entitled to benefits. And we can take a look if there's someone that's not
Just to
receiving
clarify,
that.
I'm talking about they have a part-time job in one bargaining group and a part-time job in a different bargaining group.
Right, but again, we look at just in whole,
They're-
it should be that they would be considered a full-time person as a district employee.
All right, thank you.
Yeah, because a lot of times we'll have, maybe a school food service working at another position. That's not that's not unusual, but if you have an example, that would be great. And if I can get an example, we can look for others who might be in a similar situation.
And so the key is though that if there are two part-time jobs, that both jobs are regular, right?
Yes.
It's not a,
Correct. It
not a
has to be
temp job, right.
regular positions.
All right.
Understood. So it'd be something to contact human resources or relations about. Okay, thank you.
Okay. All right. The next one is clarification of language. Ensure it's clear the employees must proactively elect and set up their health savings accounts in order to receive district funding as noted. Nancy, do you want to talk about that at all? How you know it's necessary?
Yeah, and Marilyn too can speak to the specifics, but we have low enrollment in the health savings account. So we just want to make it abundantly clear in our communications as well as in your contracts that the employees have to do something. I mean, the district will fund those health savings accounts, but the employees have to be proactive in setting them up. It's just not automatic. And I don't know that the language is clear enough to really kind of drill that home. Marilyn, do you want to speak to that a little bit further?
And it's mainly at open enrollment. During open enrollment, spending accounts in general, whether it's dependent daycare, flexible spending, or HSAs, it requires an active election each year. You would have to, even though you may have had, an HSA or an FSA, each year you have to say you either want it again, put in a new amount. And so what happens is there are many people that are enrolled in a high deductible plan, may be eligible, but there are some eligibility questions they have to respond to say they can enroll in an HSA. And people are just failing to do that. And I routinely and on a quarterly basis push out an information to people who have a CDHP or a high deductible plan, but are not enrolled in an HSA. I provide a link to, give them what the eligibility criteria is, a link so that they can activate an account, and still they don't. So I just don't want it to be that it's assumed that if they have a high deductible plan, that's all they need to do and they'll get the district funding, and then come back later to say, well, I want all my money from, 3 years ago. We can't do it that way. So I just wanted the language to be tightened up to make it clear that the district cannot just automatically give them the money. They do have to, number one, elect the account and make sure they have an active, open account.
So, because I don't have any personal knowledge with it because I'm in the low, but so if a person enrolls in it 1 year, and again, they have to do it each and every year, are they prompted prior to the next election cycle to say, just a reminder, if you do not renew or reactivate or reauthorize this, you will not have access to, because presumably people that let that lapse, it's not because they don't want it anymore. It's probably because they don't realize that they have to do it on an annual basis. Do they get any sort of reminder or?
We do it in several ways, when they're in the system itself. For someone who maybe doesn't log into our system, but in the system itself, we have prompting questions before they can move on. So before they can even go into their medical to make elections or changes, there's something there that tells them that an HSA requires an active election. If they choose a CDHP, it will prompt them that, there is an HSA, a complementary HSA. My quarterly pushes literally say, you're leaving money on the table. Here's a link, open the account. So we do as much as we can do from the peripheral. And the great thing is with an HSA, that's the one pre-tax benefit that they can sign up at any given month. It's not just at open enrollment. So as much as we can do, we are doing. And I wish I had that, easy button to figure out what that magic sauce is. But I just want the contract language to have some parameters so that with all that we're doing, I just don't want to ever get into the point of where we didn't make it clear. Unless you're doing it, we can't give you the money.
And is there some legal reason that requires it to be annual versus, I guess, like if I'm in a particular health plan, I don't have to select every year to be in the low option, like that's forever till I change it. Is there no way to make this, if I'm in it?
I can't presume. I mean, there are some, the moment you become eligible for Medicare, if you become eligible for another health plan, there are some criteria that you have to specify. I still meet the eligibility criteria to sign up for the plan.
Okay, and I guess during the open enrollment period, there are some things that we could potentially do to help this, because I do know that it's not a part of a default action. So if it's a required action for them to sign up, then they, really need to be reminded if you have one, and if you can kind of give us the information, we'll be glad to share that with them to make sure that they know that this should take place. Not that it will catch everybody, but we can catch some of those who would at least listen to the notifications that we give. Because what's sad is when they, have a real need for this, and then they end up not being able to get it because they just forgot. Kind of like with the health rewards that
Exactly.
I think that's a great idea.
Yeah. And this is something, like I said, because they can sign up, and then, we, for administrative purposes, we'll make changes the first of a month. But this is something that can be a standing item if you have, meetings or whatever. If you're enrolled in a CDHP and you have not opened an HSA, there's district funds. So it's something that you can promote because, we can make those changes. Okay.
It would just need some language on how to promote it.
Yes.
So,
Yeah.
good idea.
Thank you.
Help me, Marilyn, I'm just a little confused. And you do that during open enrollment, or you can do it at any point in time in the year?
The election of the HSA
Mm-hmm.
can be done. You can drop into it, stop contributions, increase contributions, or indicate you want the district's contribution only. That's the one plan that is pre-tax that is not restricted to just open enrollment. So you can do that at any time.
Okay,
All
thank
the
you.
other plans are irrevocable, elected at open
Right.
enrollment, and you're locked in.
Gotcha. Thank you.
All right. All right. The next one is just some date changes. And then the district agrees to be available for meetings on a monthly basis if requested by coalition members. So here it's not as though that we don't want to meet or anything like that, but I think that there will be months, maybe, specifically in the summer, where it's hard to get everybody together. But we do fully intend on continuing our meetings, regular meetings, those quarterly meetings, and obviously through the, wrapping up coalition bargaining. So the next one is 8B. So this is no change. It's just cleaning up the language that was added back in 2019 for the exclusion of Walgreens. It's just really grammatical changes. And under 13B, this is something that is a little different. So, and we could have a discussion about it. So right now, we're carrying through the, somebody who terminates the end of the contract year, and the district insurance carries for June and July. So it ends July 31st, right? So right now, I believe when this was initially done, it was school year ended often in June, right? And now the past few years and two calendars that were approved last night will be ending in May. So we're carrying insurance for anyone who's terminated at the end of the year for 2 months rather than 1 full month following their last duty day. So that's some consideration there.
This is a Diane Howard legacy item right here.
Is it?
This one had come up in
Oh,
conversation before. Yeah.
well,
Yeah, we went back to the calendars and I said, at least let's have some discussion because, I think in all the time that I've been here, the last year was the first calendar year in the last 14 years of where we had, I think it was SEIU, their union group ended in May. Teachers continued to June 3rd or so. This year, it's even growing because now most of the groups are ending in May. So it's just here to highlight, to talk about, because I don't know if the intent was for people who are leaving, that it was truly the intent to give them as a month or more, or was the intent to extend benefits for a month?
well, and I think regardless of what the intent was back then, I think what we're looking at is now going forward, right? And now going forward, obviously we're sitting here talking about ways to contain some costs and keep, keep our employees from having increases to the premiums. So over 9 and 10 years to have no increases, to try to continue that, we are looking at ways to, control some of our costs, and having 2 months beyond their last duty, 2 full months that they didn't work a day in it is, something to at least discuss and look at as an option.
Do you think that a consequence of this could be that certain employees, depending on their positions, of teachers, for instance, if I was going to quit or resign the last day of a school year, this would then prohibit the continuation of insurance through the summer. But if I don't tell you I'm going to quit or resign until the last week in July, or I guess once July 1st is passed and I get my July health care, is that not a consequence that this could delay people's announcements of their departure? Because that would be the division here, is if I tell you I'm leaving versus today
Right.
or a month.
No, I follow. Yeah.
We have that situation now anyway.
Right.
Historically, one of the reasons that teachers delayed,
Correct.
they didn't fully understand
Some
that
didn't even know that
they didn't
that it
know the
did
insurance
continue.
was gonna
They
carry
thought,
through.
it would be done.
So I don't know that it would impact it one way or the other.
And you literally are having everyone fall into this group, whereas it happens right now anyway, where people still wait until, August to say, oh, I'm not coming back, or I moved to Maine in July. And I know there's some language in the contracts about an incentive to let you know that they're not returning early. I don't know if that's in all the contracts, but it's in CTA.
But I mean, we're talking, that's like January.
I think that's
It's what's that?
that's I think
February 1st.
explicitly
February
a
1st,
reference to retirement too.
Right.
Oh, okay.
Yeah.
Right. It's
But it's an issue that has come along. It has a financial impact, not only just, missed premium collections or contributions, but also claims dollars. So there's a financial impact.
Are you able to, just for the sake of knowing it, average the employee turnover, go back 5 years or whatever and find out how many employees might have been able to take advantage of this to put a dollar tag on it?
I kind of did a throw in the dark. The difficulty is, of course, with all of our plans and all of the tiers, but lowballing it, you're close to 250 to 300 5,000 just for that, that extra month of coverage, with an average of, and that's lowballing it because that's just using the single rate. So it's in that ballpark of nothing to sneeze at.
And Jim, I would ask, does your system have the capability of looking at terms as of a certain date and claims incurred for those people that termed? Like, so I mean, I'm kind of a data nerd, and I've been thinking about that same question. How do we, how can we get a 5-year look back to see how much we really paid for these folks?
If you looked at terminations as of July 31st,
Yeah,
and
yeah,
the
we-
claims dollars.
We
for
could
that
look
group.
at like July last year and the previous, at least 3 years, we could pull
Yeah.
pretty quickly.
People with term dates, not COBRA, just active employees with term dates.
And then see how much the claims were in that last month of service. If that, that were, yeah, we can look at that.
That's
The other
important.
piece of that is our premiums are paid in 22 pays, and it covers through that time period. Is that how that's structured?
We actually have a group of folks that do have 22 pay, but the bulk are 26 pay employees, so it's 24 deductions throughout the year. But we would look at all of that because right now, yes, you're right, the 22 pays are carrying them through July, but we could look at what that impact is.
So objectively, at least for our bargaining unit, our employees pay for 12 months worth of healthcare during the school year. So they are, at least our members are paying for those 2 months. Otherwise, their monthly premiums during the school year would be lower because they'd be spread out over 26 pays.
Well, we would look at currently right now, we have to do adjustments in many cases. So you have the employees that are going to lose the coverage at the end of May if they leave before the end of the contract. There's special contract language and special codes we put in the system to extend the benefits. And currently, because it's set up to take them through July, that's what happens. Summer
That's why they
pay
continue
cycles.
paying it.
Yeah, so summer pay cycles come into play. But if we agree that that's not the way to go to continue for 2 months of coverage, we would adjust the mechanisms of how premiums are taken.
Or at least for those employees that were to leave and no longer be able to access this, they might be owed some sort of monies back because they had paid for the full year. But
No,
No.
the way that it's set up is to force, normally it wouldn't happen. So we've put special codes to force this to occur. So we'd have to look at, because we are taking deductions out of balance of contract pay. If that were not the case and we didn't use the special coding that forces it to go into July, it would go to June.
So rather than being deducted for, in your balance of contract pay, your summer paychecks that you get, there would be less taken out because you're not going to be, you wouldn't have your July payments taken out, let's say.
And the other side, in looking at this, is ACA requirements of people and losing insurance earlier before they gain additional employment or something like that. That would be something I would be concerned about, how people would be adversely impacted in that regards. Because as you know, things are going up all around, and healthcare, could possibly be a challenge. So I think that, excuse me, now is probably not a time for us to look at less coverage as opposed to more coverage. Just something to think about.
Well, and that's why we haven't proposed specific language changes, because we wanted this discussion to get your
Discussion, right.
thoughts. But we will get the numbers to see really what the exposure is. But if people leave during the plan year or the school year, so they leave in December, they've got some great job out of state, then their benefits are not extended that extra month. So
The end that month, the
yeah.
end of that month. So
You mean people who leave in December?
Yeah, it
People
ends
that
December
leave-
It ends
31st.
December
So
31st.
the normal eligibility rules, because like I said, we've had to set up special things to make this happen. So the norm is at whatever point you leave, you're supposed to work the majority of the duty days in a month to be eligible for coverage. And if you leave, your coverage ends the last day of the month in which you terminate or resign,
Right.
outside of this special language.
Right, and remember, and you mentioned this about when it started. Um, Part of that had to do with making sure that teachers stayed until the end of the year. That's why the February 1st issue is there. If you let us know, so we can go ahead and begin it with employment. But also the 31st is there so that so that you will stay until the end of the year, and we won't end up having empty classrooms because you decided to leave in April as opposed to finishing out the year. So that was a benefit for the district. And so I'm just saying that those are
It's
reasons
still benefit of June,
as to why.
where they wouldn't if they left earlier.
Yeah, and I think maybe in kind of thinking of if we were to consider language change, we still would look for that objective to say that there still is an extension of coverage. So in the contract years that end in May, we still would be technically doing what that was, is to give an extension of an additional month of coverage after you complete your contract. It's just that, and we would change language if there was agreement to do so, that it would state it that way. You would have an additional month of coverage after the end of a contract period. So whether it was the calendar shift again and we move to where contracts end in June, it would take them to July. But in the
Right, this would
years that it
only-
ends in May, it would take them through June.
So the only year it would impact is if the school year ends in May, which it is, for the next 3 years. So, all right. Well, it's something we'll look into a little bit deeper and get some numbers for you so we can all really, know what we're talking about if we do decide to make any changes.
And can I just ask a question? For those that do take advantage of the notifying of early, is that something, who has that type of data?
The district would have. 'cause they-
Notify early that they are
So
retiring.
in the contract language,
It's very
there's a
minimal,
bonus.
but they would be able to pull that in HR because you get a
It's a payment.
supplement for it.
Okay.
All right.
I think it's 500, right?
Yeah, I believe so. Yeah.
Not a lot, not a lot, but something.
Minus standard deductions, I'm sure.
Sure.
I've got that attached to every number, minus standard deductions, right? All right, the next article, section 14D. This is just a cleanup. It says in calendar year 2018, 2019, 2020. So now it just says on-site biometric screenings. So that's just language change, cleanup. And then the next one is 17, section 17, the district on-site employee clinic. So this is, it said the district will establish. Well, the district has established. So it's just a cleanup of the language that's there.
Is there a way just to pull the annual usage data from the creation of that, just for curiosity's sake, to look at how many employees, or not just how many employees, but how many trips and costs of operating a clinic versus the revenue? Just because I'm curious, because that speaks to the long-term viability of it.
Sure. Yeah, and one thing we're doing right now is we're doing a bid for pre-employment drug testing, which we're still going to offer through the clinic, but also at different locations around the county, because they're spending a lot of time doing pre-employment drug testing. And with the hiring boom, hopefully this summer, we're hoping we have a huge hiring boom. They're just going to be slammed. We won't have that contract in place in time. But after we get that in place, we really want to market the clinic. Because I've talked to people right here in the building that don't know we have one. So we really want to hammer out. There's a small trend upward with utilization, but I think we can do better, and we'll get you that information. Because if our people, us and our coworkers, are going to the clinic, then, that should help with the cost of the health plan. That's kind of what we're hoping to achieve. So it's very slow on the uptick, but I still have some optimism there that it really could be a useful tool.
When you were at the county, like how knowledgeable or how involved were you with, the clinics, I don't know a lot about them, but that fire has, or does PBSO have their own?
So PBSO has kind of a Mac Daddy of clinics. I wasn't involved because they're a separate constitutional officer. Fire Rescue, though, they did not set their clinic up with a goal to save money. They really wanted kind of a concierge operation that had a lot of bells and whistles. So my clinic for general employees was just occupational only. I felt that we were too big geographically to really drive, and it's not just my feelings. The actuary did a study on it for us and showed that we'd probably save about 3 million, but it would cost us about, 6 million to be able to put clinics in areas that would serve our folks. So I've always thought that we're too big, but you all worked with Diane in partnership, and we've got this thing. So we're really committed to trying to make it work. And it's very nice. There are some bells and whistles over there.
And we are still working on some marketing.
We are, but we want to get through the drug testing for the hiring this summer before we really start pushing it. But Marilyn points out that there's like 8,000 employees within 5 miles.
And that's what the sad timing of it having to open in the middle of COVID,
Yes. Yeah.
it certainly didn't endear people to think about, oh, I'm going to go to this new place for medical treatment while.
Right.
So
So we've neutralized that pilot program language in our draft, and but we still want to watch it. And I think we'll just all work together and determine if it's really viable over the next couple of years.
Is that clinic the only place for pre-employment drug screening now?
Right now it is, yeah,
Oh,
yeah.
okay.
But it's just, because they're decentralizing fingerprinting, so it makes sense for us to offer that same option for drug testing. So, yeah,
And
I think
we
that.
want to discuss about the Inspector General.
Oh, yes, we just wanted to give you a heads up that the IG did an audit of our dependent eligibility management. Are we making sure that people are on our plan or actually supposed to be on our plan? And so one of their recommendations was that we do a kind of a deep dive audit for our dependents, because there were some documentation issues that they found. So we agreed to focus on married spouses and domestic partners, because what happens, and we've done this in the past, Diane did it, I did it over at the county. What happens is that divorces can occur. So I can show you a marriage. I got married in 1987. I can whip out that certificate, and I'm happily still married. But in Florida, if you get a divorce, and in fact, anywhere, a judge might tell you that you have to cover, as part of the settlement, you might have to cover that former spouse on insurance. But we don't care necessarily for our health plan. We cover married spouses and domestic partners. So if you're divorced, you have to find coverage elsewhere if you have that order. But people don't know that. They're not thinking about the rules. And so they may carry those spouses post-divorce, and we have no way of knowing that. So we're working through the logistics of doing that audit.
And so we'll provide updates when we have more information, but we wanted to just give you a heads up on it.
So there will ultimately be like a summary report from the IG, like detailing their findings and work with you.
Yeah, we actually do have that. We have that final report.
Is that public yet? Or is that?
Is it public yet? That's a really good
I'm not sure.
question. I will find out and definitely share it with you.
If it's accessible, I'd just be curious, because it is an interesting topic.
And when I say public, has it gone through the audit committee yet? I don't know, but we're, it's a public record, so to speak.
Yeah, I think
so-
once it's produced
Not
and
that sexy.
finalized by the IG, there's some.
Right.
Okay.
So we'll find out and we'll share whatever
Right,
information
yeah.
we can.
So we're,
So
And it's really to
Yeah.
tighten because of those circumstances. When you're doing a verification process. You know, unless you're asking people on a regular basis, have you gotten divorced? Have you this? Have you that? You're not going to get that kind of information. It's self-reported. So, you know, the recommendation, we were going to start there to actually look at that population and say, of the folks who are telling us they have a spouse. And we still have to come up with what documents would we consider, you know, accepting as proof that they're still legally married.
All right. Well, that's all we had for today. Mr. Moore, thank you so much for taking the time to do that presentation. It was really great. And, thank you everybody for joining today. And we'll look at scheduling our next quarterly meeting. I guess be sometime probably in August. But if there's any need to meet sooner, or if we have something where we feel we can meet sooner to finalize anything or try to reach an agreement, we will. And I know during the summer, everybody's schedule is kind of hard to connect, so it might have to wait until August. Any last questions from anyone?
Yeah, for me, excuse me. The plan changes. I guess I would like a better understanding as to what they are and how they will play out in the current
Recommended
coverage.
changes, you mean?
Right, I saw the numbers and all that, but exactly what does
What does
that
it mean?
Yeah, what does it mean?
Got it.
Right.
And somebody online, Mr. Voss?
Yes, looking forward, I was wondering if we've ever taken an interest on some of our members are older and qualify for Medicare, and some of our members on the lower income side qualify for Medicaid, and perhaps we can, you know, provide healthcare services in both a way that would save the district money and give them the eligible health care, a package that would blend in with either Medicare or Medicaid.
I'm not sure that we can do that because Medicare, for example, is that voluntary? I mean, most people want to stay on their cover. As long as you work, you can be covered by your in fact, the federal government wants you to be. It's coming back to me now. The federal government
coordination
really doesn't want they want the employer bearing the cost as long as the employee is working.
Well,
And
I
then
mean, there are
Medicare
employees we
comes
have
into
that
play
are
when they
working past
retire.
65.
I'm sorry, I couldn't hear you, Stephen.
I'm saying there are employees we have that are working past 65 that are Medicare eligible, yet they don't have to, you know, ask. And I'm saying, and I know some of them right now, I'm recommending that, you know, I guess they can use the low end HMO and say, use Medicare as their secondary coverage. But I'm saying if there was more counseling about that, because they could probably get better coverage from having both policies after 65 by having the district as a secondary or primary and Medicare as a secondary. That means reduced copays for them.
Well, the only thing is, you know, there's a couple of pieces there. If someone is 65 or older and they're still actively working, unless there are some other situations in stage renal, their Medicare coordination rules that would still, regardless, the district would be primary. And because we are HMO based for most of the employees, there's not going to be much advantage to that Medicare coming in. Our copays and deductibles are relatively low in comparison to for them to sign up. But employees do have the choice to sign up for Medicare, and they can waive our coverage, and that is a life event should they do that. But in a lot of cases, it's not something that I would feel comfortable making a recommendation to someone just to say, go get Medicare and get off of our plan.
No.
Sometimes people stay on our plans
I'm
because
not
of
even
the
talking about that.
the
They can
prescription
split-
drug plans.
I'm not talking about that. I'm
No.
talking about, for instance, shifting from the high-end HMO to the low-end HMO, which doesn't have any premiums, and then using Medicare as a secondary. You know,
We'll look further into it. I don't think we're prepared really to have that discussion right now. We'll look into it though, and in the next session or before we'll get any sort of response to that.
okay, that's
You have any?
Well, I used to be an insurance agent, so I could answer those
Oh.
questions, but I'd rather you all
Yeah.
handle it your way and.
All right.
set it.
Thanks. All right, everybody. Well, thanks again for being here today. Ms. Bolton, thanks for putting all this together. Appreciate it. And we will be in touch soon to schedule our next session. All right.
It was productive. Thank you for your time.
Thank you.
Appreciate it.
Thank you.